So good morning, everyone. For those of you that don't know me, I'm one of the R2s in the emergency medicine program here. Thanks for all tuning in to my presentation. It's on checkpoint inhibitor toxicities in the emergency department. And just as a bit of housekeeping, we're going to answer questions. Rhonda Ness is going to help me moderate at the end of the presentation. But if you have any questions, feel free to put them in the Q&A chat. And if your question is already there or if someone's already asked it, you can just I guess, the question, and it makes it appear higher up for us to answer. So I have no disclosures, and I wanted to start off by acknowledging everyone that helped me in creating this presentation. So Dr. Monzon is one of our medical oncologists and offered up a lot of his time to help make this presentation possible. Thank you to all my ED mentors who contributed to this talk. And I wouldn't be able to present today if it wasn't for Aaron Peterson. We all really appreciate all your IT support. Phil was very helpful, as always, in teaching me more about these drugs, and no presentation would be complete without Don May's help. So the objectives of this presentation are to explain what checkpoint inhibitors are, to go through their side effect profiles, and lastly, to talk about the workup and management of their associated toxicities. To properly introduce the topic, I want to speed through a very brief history of immunotherapy, really only including what I found interesting, which starts in 1796 with a smallpox vaccine. So Dr. Jenner was an English physician who was inspired to research as well as contribute to this vaccine after he observed that milkmaids were generally immune to smallpox. He postulated that the pus in the blisters that the milkmaids received from cowpox, which is a disease that is similar to smallpox but much less virulent, protected them from smallpox. So he performed his first vaccination on an 8-year-old boy in 1796. He inoculated the boy by scraping the pus from cowpox blisters on the hands of milkmaids. And after inoculation, the boy felt unwell, a little bit febrile, but never really mounted a full-blown infection. Subsequently, when he was inoculated with smallpox, again showed no signs of infection. And the next big breakthrough came in 1893 with Dr. William Cooley, who's now known as the father of immunology. He was an American surgeon who encountered a patient who underwent surgery to remove his sarcoma. Intra-op, it was decided that his cancer was too extensive to resect. However, shortly after the operation, the patient developed erysipelas and his tumor completely disappeared. Dr. Cooley then decided to inject streptococcus into all cases of unresectable sarcoma that he encountered, and he treated almost 900 unresectable sarcoma patients, achieving a greater than 10% cure rate with his Cooley's toxin. The first immunotherapy agent was FDA approved in the US in 1986, and that was interferon. And after this, we see new classes of immunotherapeutics being described and then approved for use. So today, various cancer immunotherapeutics exist, and they're classified as either passive or active agents. Checkpoint inhibitors are classified as passive immunotherapeutics, which do not directly stimulate the immune system. And then it was in 2018 that Dr. Honjo and Dr. Allison were awarded the Nobel Prize in Physiology or Medicine for the development of this revolutionary new cancer therapy. And very simply put, the pair demonstrated how we can manipulate the immune system so that it attacks cancer cells. And the first checkpoint inhibitor was FDA approved in 2011. And this immunotherapy is currently being utilized in more than 14 different types of cancers, including metastatic melanoma, non-small cell lung cancer, renal cell carcinoma, squamous cell carcinoma, as well as urothelial carcinoma. So to demonstrate how this new therapy will impact us as emerge physicians, I'm going to highlight a local case. This was a 68-year-old male who presented to one of our emergency departments. The triage complaint read, reports vomiting for 5 days, unable to keep anything down, denies abdo pain or fever but feels weak, and on immunotherapy for melanoma Q12 weeks. On a chart review, this patient presented with a 4-day history of both diarrhea and vomiting. His past medical history was significant for recurrent metastatic cutaneous carcinoma, and he was started on a checkpoint inhibitor a couple months before his initial ED presentation. His last treatment was 16 days prior to that visit. His blood work was unremarkable, his vital signs were stabilized after IV fluid, and he was able to be discharged home. This patient represented to the emergency department via EMS 4 days later after he was found pulseless and cyanotic. His building manager had been notified of flooding in his apartment by the tenants that lived below. Upon entry, EMS noted the apartment to be in disarray, feces all over the ground, and the patient was found in the bathroom. After one round of CPR, he began to take spontaneous respirations and move his extremities, and in the ED, he was found to be a GCS of 8. He was mottled, cold, as well as dry, and he was started on a norepi infusion and very quickly intubated. He was found to have a significant metabolic acidosis, a leukocytosis, an AKI, and an elevated urea. His ECG was unremarkable, and his tox workup was negative. He had a CT of his head, chest, abdo, and pelvis that did not reveal obvious cause for his shock, so he was treated for presumed decompensated septic shock. He continued to have significant diarrhea while in the department, and his blood cultures were eventually negative. ICU was consulted, and the patient was transitioned shortly after to a C2 goals of care after speaking with family. His cortisol was normal the month prior to his ED visit, but later in the presentation, we'll touch on how adrenal insufficiency is a consideration for this presentation as well. So in light of a thorough workup, it was the thought of the EDMD, ICU, and medical oncology that the etiology of his hypovolemic shock was likely ongoing diarrhea from his checkpoint inhibitor therapy. So these are checkpoint inhibitors. And after I watched the following video and about 50 more videos, I found diagrams like this a little bit less overwhelming. So this is a brief introduction to checkpoint inhibitors. So to summarize some of the video, the immune system has multiple checkpoints. These are pathways that serve to either upregulate or downregulate the immune response. So in a healthy person, inhibitory immune checkpoints reduce autoimmunity. However, in an individual with cancer, these checkpoints impair the immune-mediated clearance of cancer cells. Cancer cells then use these inhibitory checkpoint molecules to evade the immune system. Therefore, by blocking these checkpoints, aka inhibiting the inhibitors, we're helping our immune system to recognize and attack cancer cells. There are multiple immune checkpoint inhibitory pathways that are currently being investigated. Right now, our therapies are directed towards cytotoxic T lymphocyte-associated protein 4, so that's seen here, or anti-CTLA4. as well as programmed death receptor 1 and 2 as it interacts with PD ligand 1 and its pathway, so seen here. And by blocking these checkpoints, again, inhibiting the inhibitors, we're helping our immune system to recognize as well as attack cancer cells. So the best analogy I could come up with involves bouncers and teenagers. I liken cancer cells to teenagers with fake IDs, and with their fake IDs, they're able to evade detection of bouncers, aka our immune system, and get into the bar. Checkpoint inhibitors have been designed to affect the interaction between bouncers and underage teenagers, and these drugs effectively swipe their fake IDs so that when underage teenagers present to the bar, bouncers are able to redirect them back home. In Canada, there are 7 checkpoint inhibitors that are approved for use, and the most common ones that are being utilized are ipilimumab, nivolumab, pembrolizumab, and atezolizumab. And this is still how I feel every time I have to pronounce these drugs in front of our med-onc colleagues. So ipilimumab was the first drug to demonstrate improved survival overall in patients with metastatic melanoma. This was the original ipilimumab trial, and it was a phase 3 double-blind RCT. And essentially they compared 3 different groups. So ipilimumab alone, ipilimumab with control, and then a control group alone. And for some context, the control group was a drug called GP100, and it's a well-studied cancer vaccine that also induces an immune response, but has limited anti-tumor activity. So we can clearly see that either ipilimumab arm is superior in median 1 and 2 year survival when compared to control. And it was this trial that led to the approval of this drug in 2011 by the FDA. Subsequently, RCTs involving a multitude of different checkpoint inhibitors again demonstrated substantial anti-tumor activity. And this has led to their approval and then use in Canada for 14 different cancers, including, again, metastatic melanoma, non-small cell lung cancer, renal cell carcinoma, squamous cell carcinoma, and urothelial carcinoma. So as a review of objective number 1, checkpoint inhibitors are monoclonal antibodies designed to ensure underage teenagers don't get into the bar, aka they're drugs designed to help the immune system recognize as well as attack cancer cells. So to cover objective number 2, we're going to review the side effect profiles of these drugs. Checkpoint inhibitors are typically administered in a regimen that consists of multiple doses over the span of months. Endpoints are variable and typically depend on disease progression or unacceptable levels of toxic effects. And depending on the cancer, some patients are getting treated with immunotherapy alone, for example, melanoma, whereas some patients will receive chemotherapy as well as immunotherapy. Lastly, it's not uncommon for patients to be treated with 2 checkpoint inhibitors at the same time, and that's referred to as combination therapy. So there were no charts from 2013 to 2019 that specify anything related to checkpoint inhibitors in our ED discharge diagnoses. And I think that there are probably 2 reasons for that. Number 1, this is a tough diagnosis to conclusively make in the ED, and I'll elaborate on why later in the talk. And number 2, I did a small chart review of our ED data, and I think we are both mislabeling as well as potentially missing this diagnosis. Many charts were labeled with a discharge diagnosis of an adverse event related to chemotherapy when patients were actually on checkpoint inhibitor therapy. So all that is to say is with the growing popularity of these drugs, we'll see more and more presentations related to their toxicities, and it will be our job to think about the diagnosis in order to expedite appropriate care. So immune checkpoint inhibitors have an adverse side effect profile that's distinct from conventional chemotherapy. These drugs result in toxicities known as immune-mediated adverse events, and they're as a result of an enhanced immune system response. So immune-related adverse events can affect any organ system, but most commonly dermatologic, gastrointestinal, endocrine, and pulmonary systems. So for the purposes of this talk, we'll focus on these 4 systems. Toxicities that are less common and are less likely to present to the ED are those related to hepatic, renal, neurologic, hematologic, ocular, and cardiovascular systems. The incidence of immune-related adverse events ranges from 60 to 85% with CTLA-4 inhibitors, and about 40 to 70% of patients taking PD-1 and PD-L1 inhibitors. Combination therapy has a significantly higher risk of high-grade adverse events when compared to monotherapy, and treatment-related death is reported up to 2%. In terms of our organ-specific reactions, diarrhea is one of the most common side effects of checkpoint inhibitors, seen in almost 30 to 40% of patients on ipilimumab. Our job in the ED becomes to differentiate the mild and self-limited diarrhea from more severe diarrhea and colitis that can be a harbinger of potential fatal complications like a bowel perforation. The differential diagnosis for diarrhea in these patients is broad and includes diverticulitis, colitis, enterocolitis, IBD, as well as bowel perforation. The diagnosis of colitis is seen in about 1 to 8% of patients taking monotherapy and up to 10% of patients on combination therapy. Bowel perforation is a very rare complication, but is cited at about 1% in patients who are diagnosed with colitis. So to illustrate the clinical course that some of these patients might take, this is a 72-year-old male who had metastatic melanoma with involvement of his liver and lung, and he was treated on with ipilimumab as well as nivolumab. After his first round of treatment, he developed hematochezia. He presented to the ED and was admitted for IV steroid treatment. An investigation for infectious cause of his diarrhea was negative. He was then discharged home on oral steroids. The plan thereafter was to continue on monotherapy, but before his second round of treatment, he developed diarrhea, vomiting, and abdominal pain. He was instructed to increase his home dose of steroids, but despite that, again went on to develop hematochezia. He represented to the ED, had repeat stool cultures that were eventually negative for infectious cause, and a CT was performed that demonstrated pancolitis as well as pneumoperitoneum. Of note, the patient was found to have a significant response to immunotherapy with a decreased size of his liver met by 70%. Unfortunately, he went on to have an emergent laparotomy and a bowel resection, and because of his adverse reaction, was no longer a candidate for further immunotherapy. Dermatologic side effects are also very common, and symptoms are usually low grade and range from pruritus and nonspecific diffuse maculopapular rash to vitiligo. Severe reactions are rare, but include Stevens-Johnson syndrome, drug rash with eosinophilia and systemic symptoms, as well as toxic epidermal necrolysis. These symptoms typically appear early, so a couple weeks after starting therapy, but there have been reports of delayed reactions occurring months after stopping treatment. The patient on the first panel here is a patient who developed vitiligo while on immunotherapy. And the second figure demonstrates the most common type of rash that we see, which is a reticular maculopapular erythematous rash that affects the trunk as well as extremities. In terms of our pulmonary system, pneumonitis is defined as non-infectious lung inflammation with interstitial as well as alveolar infiltrates. In patients with non-small cell lung cancer, the incidence of checkpoint inhibitor pneumonitis is higher and appears earlier after initiation of treatment compared to other cancer types. Clinical presentation often includes a dry and unproductive cough, along with tachypnea, tachycardia, cyanosis, and fatigue. These symptoms are nonspecific and can also represent progression of disease, infection, or common cancer complications like a pulmonary embolism. Fever and productive cough are uncommon in autoimmune pneumonitis and are more suggestive of an infectious etiology. And chest imaging typically shows ground glass opacities as well as patchy nodular infiltrates, particularly in the lower lobes. So these are 3 cases of pneumonitis associated with checkpoint inhibitors. All patients had advanced melanoma. So patient 1, which is seen in the top 2 panels here, so panel A and B, he's a 70-year-old male, and the first CTU is at 22 weeks of therapy. It shows bilateral consolidation, reticular as well as ground glass opacities, In 2 weeks, we see significant progression of his disease here, and he required ICU admission. Patient 2 is the 38-year-old female, and this CT was taken at 15 weeks of therapy, which again showed diffuse ground glass opacities, reticular opacities, and consolidations in all lobes. Her infectious workup was negative. She required ICU admission and unfortunately died 4 weeks after the diagnosis of pneumonitis was made. And then our last patient, seen in panel D, is a 58-year-old male with advanced melanoma, and this was an early CT taken at 7 weeks of therapy and revealed bilateral ground glass opacities, or some reticular opacities, as well as some small areas of consolidation that we can see here at the lower lung points. He was discontinued on his immunotherapy, and he was treated with glucocorticoids as an outpatient. He was subsequently able to restart therapy, and at the time of this publication was progression-free from his melanoma after 39 months and had no recurrence of his pneumonitis. Lastly, related to our endocrine system, the most common endocrinopathies described as a result of these drugs are thyroid dysfunction as well as hypophysitis. There are reports of adrenal insufficiency, hypoparathyroidism, as well as immune therapy-related type 1 diabetes. Hypophysitis is defined as inflammation of the pituitary gland or its stalk, and presenting symptoms are usually non-specific, but include headache, fatigue, arthralgias, loss of libido, and vision changes. And endocrine immune-related adverse events are unique in that they might precipitate chronic endocrinopathies requiring ongoing medical therapy many years after discontinuation of immunotherapy. So this is a report that followed 8 patients who developed endocrinopathies while on checkpoint inhibitor therapy. All of these patients elicited symptoms of profound fatigue, debilitating headaches, memory loss, and loss of libido. All patients were diagnosed with autoimmune hypophysitis by their presenting symptoms as well as blood work that showed panhypopituitarism. And 7 of the 8 patients had a significant increase in size of the pituitary gland, as well as significant supracellular extension. So 1 year later, all 8 patients still required hydrocortisone therapy, and 3 patients required ongoing thyroid replacement, as well as testosterone replacements. Hepatitis is usually asymptomatic and detected by routine LFTs. Generally, we see elevations in ALP as well as ALT, occasionally in bilirubin. So after other causes of liver injury are considered and are ruled out, treatment is typically only recommended after ALP and ALT values exceed 3 times the upper limit of normal. Adverse neurologic events have been reported from Bell's palsy to encephalopathy. There are reports of transverse myelitis, GBS, as well as myasthenia gravis. Renal injury typically mimics that of drug-induced tubulointerstitial nephritis. And pancreatic toxicity is actually quite rare. Lipase levels may be elevated in relation to checkpoint inhibitor therapy, but it's often clinically non-significant and does not need to be trended. Hematologic toxicities have been reported from autoimmune hemolytic anemia to ITP, lymphopenia, as well as acquired hemophilia A. There are a few case reports of checkpoint inhibitor myocarditis and associated heart failure. And ocular changes have been reported from episcleritis to conjunctivitis, as well as uveitis. So the US National Cancer Institute has created a grading scale for understanding and defining adverse events related to the use of any medical procedure or treatment. And this is how we grade adverse reactions related to checkpoint inhibitor therapy. So grade 1 is defined as patients who are asymptomatic or have mild symptoms. These patients require observation only, and intervention is generally not recommended. Grade 2 is defined as patients with moderate symptoms that limit activities of daily living, and non-invasive intervention is usually required. Grade 3 adverse events are disabling and limit all activities of daily living, but are not immediately life-threatening, and these patients require hospitalization. And grade 4 adverse events are those that are life-threatening and require urgent intervention. Lastly, grade 5 is defined as death related to any adverse event. In general, adverse events occur within the first 12 weeks of therapy, but may occur up to 6 months after discontinuation of treatment. The timeline of immune-related adverse events is heterogeneous, but there have been some reports of trends that are being observed. So this was a pooled analysis that was published in 2017 from the Journal of Clinical Oncology that aimed to characterize the safety profile of regimens that included nivolumab and ipilimumab, and these were all patients who had melanoma. So they included 450 patients, 95% of which experienced adverse events related to their therapy, and 55% of those experienced high-grade adverse events, so either grade 3 or grade 4. So this was figure 3 from their paper, and it outlines the time to onset of these grade 3 or 4 adverse reactions. The colored boxes here represent the interquartile range. The center vertical line represents the median time, and the outer vertical line represents the range. So median time to onset of these high-grade adverse reactions was 3 weeks for skin and up to 16 weeks for our renal systems. This was a portion of figure 4 from the same paper that outlines the time to resolution of these high-grade adverse events. The median time at shortest was 1.9 weeks for our renal system, and at longest was 15 weeks for endocrine systems. Median time to resolution was 5 weeks overall, with the exception of endocrinopathies, and the majority of these patients were treated with steroids. So we can contrast and compare the adverse effects of chemotherapy to that of checkpoint inhibitor therapy. As I highlighted before, the timeline of immune-related adverse events for checkpoint inhibitors is heterogeneous, and this is contrasted to chemotherapy, where there is somewhat of a predictable time course of oncologic emergencies relative to treatment. For example, with febrile neutropenia, usually we see it present 7 to 14 days after last chemotherapy treatment. So despite reviewing all of the scary adverse effects of these drugs, Dr. Monzon emphasized how well tolerated checkpoint inhibitor therapy is in comparison to standardized chemotherapy. So this was a systematic review that compared the safety and efficacy of chemo and other monoclonal antibodies to checkpoint inhibitors in patients with non-small cell lung cancer. The study included 11 RCTs and compared 9 different drugs, 3 of which were checkpoint inhibitors. So nivolumab, pembrolizumab, and atezolizumab exhibited dominance in safety as well as efficacy over all alternative therapies when looking at grade 3 to 5 adverse outcomes. So this was a figure from their paper, and it's a cluster ranking plot, which demonstrates effectiveness and safety of each of the drugs compared. And interventions in the top right-hand corner tend to be more effective as well as safe compared to anything in the lower left-hand corner. So lastly, for patients that present to the ED on chemotherapy, I commonly think about ruling out opportunistic infections. In contrast, because checkpoint inhibitors actually ramp up the immune system, the incidence of such infections is actually quite low, with the caveat being any patients who are on immunotherapy plus chemotherapy, or any patients who are on immunotherapy and now on corticosteroids to treat the side effects of their immunotherapy. So this was a retrospective review of about 750 patients with melanoma who were treated with a checkpoint inhibitor. Serious infections were reported in 7% of all of these patients, most being bacterial in origin. The most significant risk factor associated with serious infection was the use of corticosteroids. And overall, the risk of serious infection was 13.5% in patients that received corticosteroids and only 2% in patients that did not. As a review of objective number 2, checkpoint inhibitors have a side effect profile that is distinct from conventional chemotherapy. These drugs result in toxicity related to an enhanced immune system response and can affect any organ system, most commonly skin, GI tract, endocrine, and pulmonary systems. These reactions can occur within the first couple weeks of treatment, as well as months after cessation of treatment, and reactions are graded on a scale of 1 to 4. Lastly, we're going to review the workup and management of the associated toxicities of these drugs. So the primary objective in our workup of these patients is to rule out infection or progression of malignancy, and then to assess grade and severity of their symptoms. General GI workup should include routine stool testing for C. diff as well as O&P. And recommendations are to have a low threshold for a CT abdomen if patients present with a story that's concerning for colitis or perforation. The key to investigating dermatologic reactions is to try and rule out any other cause for the rash. And for any rash graded 2 or higher, we should consider dermatologic or dermatology involvement for a biopsy. And for patients presenting with non-specific endocrine complaints, the recommended workup is varied, but typically includes a TSH and glucose, and if suspicion for adrenal insufficiency, a cortisol as well. And lastly, for our patients that present with respiratory symptoms, our workup should include a chest x-ray as well as sputum. Routine chest x-rays can miss up to 25% of cases of pneumonitis. Therefore, CT chest should be considered in all patients with a negative chest x-ray and clinical suspicion for pneumonitis. Standard treatment for the most part for all of these adverse side effects is corticosteroids. So Cancer Care Ontario has come up with a toolkit to navigate adverse events related to checkpoint inhibitors. The guidelines were intended for all clinicians involved in the care of patients on this therapy. And although they're not specific for emerged providers, they're certainly helpful in helping us to work up as well as disposition these patients. In speaking with our medical oncology colleagues, they agreed that these guidelines would align with the care we provide in Calgary. And I've attached a QR code that will take you directly to their website. Same QR code in all of the next few slides. So here's an example of a simplified version of one of the toolkits. So we'll walk through it together and use the case at the beginning of the presentation as an example. So as a reminder, we had a 68-year-old male who initially presented to the ED with 4 days of nausea, vomiting, and diarrhea. I don't know the specifics around his first presentation, but for example's sake, if we were to assume he was having 4 to 6 stools above his baseline, then he would potentially be considered as having a grade 2 adverse reaction to his immunotherapy. Our workup would necessitate ruling out other sources of diarrhea with basic blood work as well as stool cultures. And if diarrhea has been going on for more than a week, or there's question of grade 3 or 4 diarrhea, he should be considered for a GI referral for colonoscopy. Again, guidelines stress that before moving on to any kind of supportive therapy and deciding on corticosteroids, ruling out infection is important. So for this patient, if our workup is negative or our suspicion is very low, then supportive therapy options would include fluids as well as loperamide. And the most important step is involving medical oncology to discuss starting prednisone as well as the dose of prednisone and potentially withholding immunotherapy. So Dr. Monzon wanted me to pass along that in all patients presenting with a question of an immune-related adverse event, medical oncology should be involved. They actually commonly admit these patients, of course, unless they're unstable because they're not an in-house service. So this is a simplified toolkit for dermatitis. Our grading is related to the predicted total body surface area that the rash affects, and the guidelines highlight that any signs of desquamation, no matter how much of the body the rash affects, should be classified as grade 4 and treated as such. And lastly, for pneumonitis, I wanted to highlight the fact that this is likely not a diagnosis we're going to conclusively make in the emergency department, as infectious cause for the respiratory symptoms have to be ruled out by definition. So if patients present with fever and infectious symptoms, it's reasonable to start empiric antibiotics, particularly if you're worried about a grade 3 or 4 adverse reaction. However, if pulmonary or ICU is consulted, the decision to start antibiotics can be a shared one, as a lot of these patients will go on to get bronchoscopy in order to rule out infectious cause, and antibiotics can affect the sensitivity of our cultures. The last point to make is that recommendations are for more aggressive investigation as well as workup of patients suspected to have a diagnosis of autoimmune pneumonitis. including early corticosteroid therapy, as well as a lower threshold to admit to hospital, even if they're not requiring oxygen. And this is because of the high mortality rate associated with this diagnosis. So as a review, if we have patients that present to the ED on checkpoint inhibitor therapy, our role is to consider the diagnosis of an immune-related adverse event, while also investigating to rule out infection or progression of disease. If there's a high suspicion of an immune-related adverse event, we need to assess the severity of disease. Typically, grade 1 and 2 reactions generally require symptomatic treatment and oncology follow-up, whereas grade 3 and 4 reactions generally require admission and treatment with antibiotics as well as immunosuppressive therapy. The last point I wanted to make is in relation to goals of care. It's not infrequently that we have goals of care discussions with our patients in the emergency department. And prior to these drugs, patients with metastatic melanoma, for example, had a typical life expectancy in the span of months. Now, some of these patients are looking at years. So though each conversation is unique and each patient's situation is different, I think it's important to keep this in mind and keep in mind that we're looking at big differences in terms of life expectancies when we're discussing this with our patients as well as their families. So in summary, checkpoint inhibitors are monoclonal antibodies that help the immune system to recognize as well as attack cancer cells. There are 4 checkpoint inhibitors currently being used, and most commonly in Canada. That includes ipilimumab, nivolumab, pembrolizumab, and atezolizumab. And if those don't readily come to mind, another clue to tip you off to think about the diagnosis of checkpoint inhibitor toxicity is to remember that these drugs are currently being utilized in more than 14 different cancers, and commonly in metastatic melanoma, non-small cell lung cancer, renal cell carcinoma, squamous cell carcinoma, and urothelial carcinoma. Takeaway point number 2 is that checkpoint inhibitor toxicities are as a result of an enhanced immune system response. Adverse effects or events typically affect the gastrointestinal, dermatologic, pulmonary, as well as endocrine systems. These adverse events can occur within the first couple weeks of starting therapy, as well as 6 months after treatment. And lastly, we discuss the workup and management of patients on immune checkpoint inhibitor therapy. It's important to consider the diagnosis of an immune-related adverse event while ruling out other causes for the patient's presentation. And our role is then to assess the severity of disease and treat accordingly using the help of resources like Ontario's Cancer Care Guidelines, as well as our consultants, so that we can expedite appropriate care for these patients. So I wanted to thank everyone for their time and attention, and for everyone that helped me put this together. These are my references, and happy to answer any questions with Dr. Ness.